So, with global funding for HIV programs under serious threat following moves like the termination of key U.S. grants, many low and middle income countries now face uncertainty in their HIV prevention efforts. However, a landmark agreement between pharmaceutical giant Gilead and the Global Fund promises a broader access to long-acting HIV prevention drug Lenacapavir. To help us speak about what this means for South Africa, we're joined now by Dr. Nkateko Msimeki, medical advisor for AIDS and general manager for health policy at the AfroCentric Group. Dr. Msimeki, a very good evening to you, and thank you so much for speaking to us.
Good evening. Thank you for having me.
I was just thinking that I wasn't sure if I was completely, messing up those names, the drug, and of course, pharmaceutical. So please feel free to correct my pronunciation. But let's just start with the big picture. What are we looking at the moment? And this partnership, this deal with Global Fund, in the context of the current low funding or depleted funding in some cases, what does it mean for us?
So, in some respects, it's a promising and exciting endeavor that we're embarking on. So, the Global Fund is looking to fund HIV access for 2 million people globally, and part of that funding, that is a 3-year funding cycle. We are being funded the equivalent of 520 million is what the government is going to set aside of the money we've already been funded by the Global Fund. So we've had a tranche of money, and 520 million of that is being set aside towards funding Lenacapavir for prevention of HIV and AIDS. So in the setting and space we are in, where we've seen the PEPFAR funding come to a sudden halt, it's a ray of sunshine to say actually we can have other sources of funding come in to continue the important work of HIV prevention, which was largely funded through programs like PEPFAR, and particularly for key populations. And there we're talking about men who have sex with men, people who work in transactional sex work, transgender people in prisons, young adolescent girls and young women. And that's exactly where we're seeing HIV infections come up and rise. And so that removal of funding by PEPFAR was a blow to those programs. So this coming in as a ray of sunshine, hopefully particularly in those spaces where we've lost funding.
I'm glad to hear you say that. And it's also quite interesting because on the announcement that there was ODA cuts, not only from the US, but other countries, including the UK, particularly the media's framing of it has been, this is a complete disaster, everything is going to fall apart. But the minister said, no, that is not the case. But that's a politician speaking. I was listening to a friend who actually was saying the very thing that you're saying, that people don't realize that the people who are going to be most affected are, as you say, those who are involved in transactional sex, men who have sex with men, because that's where the funding for these programs come from. Am I correct in that understanding?
You are. And so I think of the PEPFAR funding in terms of what it did for South Africa in two ways. There's the direct service that you would see, and there's the indirect service where the funding was going to. So from a direct service perspective is the things I've mentioned, and that's the programs that are largely run by like NGOs who've had to shut down overnight sometimes, literally got a letter that said stop, halt services immediately, don't open doors tomorrow. And there's impact to people, that's livelihood, but there's also impact mainly to patients, right? So people who are not accessing care. But there's also the indirect service that we're also not counting often, and that is what builds your HIV program. So no, that's the research. A lot of research is being funded by PEPFAR. That is the technical assistance, and then we're talking about monitoring and evaluation. Somebody has to be monitoring what is the program doing, what is the impact, where should it be focusing. A lot of that was funded by PEPFAR. That's health promotion. A lot of that was funded by PEPFAR. So the impact is actually quite diverse and quite broad. And even though we often see it as well from a public sector lens, there's a private sector component, much smaller, obviously, in that you might not experience the direct service in terms of drugs will still be accessible because they're funded through a different channel. but you'll feel it from a research perspective. So South Africa is a key leader in terms of clinical research and guidelines. All right. Even in the prevention space, a lot of trials happening in South Africa that are funded for like Lenacapavir. So we know with the Depiverine vaginal ring research happening here, the people who benefit from that is not just the private sector, it's the public sector in terms of getting local guidelines, local research. How are people accepting of these new drugs coming from international spaces? How's a South African individual accepting it? How does it fit into how we do service delivery? That's both public and private being affected. So it's quite diverse, the impact of the PEPFAR pool.
And tell us a little bit more about Lenacapavir and how it fits into the overall USAID strategy of 95, 95, 95.
So the first 95 is about ensuring that you are testing people early, right? So you want to be finding people quickly, but part of that is prevention, right? So you want to be halting HIV where we can. For a long time, part of our prevention strategy, if you think back, right at the beginning was condomization, and we've seen some of the big challenges with that in terms of consistent use, access, etc. By the way, PEPFAR funded a lot of that. And then you saw how we moved to prevention of mother-to-child transmission through tablet, and how with the drug prices coming down, we improved access for beyond just prevention from mother to child to people who are in relationships with people who are HIV positive, so for prevention purposes, so the tablet. And then we progress, and the tablet you would take it daily, and obviously that has its own challenges, right? So we see it with any chronic illness, but the difference now is you're basically saying to healthy people who are HIV negative, take this tablet every day to prevent HIV. So it means people who are not sick likely are going to struggle to take that tablet, adherence issues. We also have in South Africa issues of gender-based violence. So stigma is a big issue as well. So that also impedes people's ability to take that tablet. So science moved along to more long-acting therapy. In 2022, we had two landmark registrations in South Africa. The one was for what we call the Depiverine vaginal ring, and that's a ring you put in the vagina, and it would last for a month, slowly releasing the drug, and for prevention purposes. And the second one was an injection, so much like the injectable contraceptive, but this now is for HIV prevention, and you would get that injection every 2 months, called cabotegravir. Now, Lenacapavir is the injection, but instead of you needing it every 2 months, it's now every 6 months. So the initial one, you would take the injection with some tablets, but then you would then move on to a 6-monthly injection. So it now means that the duration of that therapy is longer. So it means for people who don't want to necessarily remember a tablet, or you've got fears of things like stigma, nobody has to know, right? It's more discreet. It's you've got longer spaces between when you need the injection. So that's where that Lenacapavir would fit in.
And at risk communities, particularly when we're looking at the girl child and young women, and also just adolescents in general, what does it mean then to face these kind of challenges? And if you could just also talk a little bit more about the importance of public-private partnerships in preventing missing some people from coverage in prevention.
So in the segment of adolescent girls and young women, so AGYW, it's one of the segments where we're still seeing transmission of HIV, and that's quite concerning. And there's been a lot of focus in terms of trying to understand what exactly does that demographic need? How do they access care? Because our general way in which we give care is not tailored for key populations, right? It's not tailored for the young girls. So they might not be going to a clinic, and you typically hear about unfriendly service, or people being shouted at, or issues around school, issues around blessed society, all these different aspects come into play. So the more you have in terms of options for prevention, it means you're better able to meet people in terms of their need. So interestingly enough, there's studies happening now around, actually it's been happening for a while now, around looking what we call implementation studies, looking at women's acceptance of the oral contraceptive versus the Tsepiso versus the cabotegravir, the injection, trying to see, do you see an AGYW accepting a certain one over another? Interestingly enough, we see some of the studies showing that women less than 25 actually prefer the oral or the injection more than the vaginal ring. And part of that is just knowledge and acceptance of the oral contraceptive. So it's something they're more used to in terms of the route. So something like Lenacapavir is probably going to be more acceptable, right, than a 3-month vaginal ring that's currently being studied. Whereas, women above the age of 25 to about 34 might prefer the vaginal ring. Women who are involved in transactional sex might prefer the vaginal ring. So that kind of knowledge that comes out of research, coming out of understanding what people need and having these different options means you're better able to tailor care to meeting the particular needs of a particular demographic. Now, partnerships in terms of public-private partnerships come in and become important. One, yes, again, for research, because a lot of research happens in the the private sector as well, be it funded by the private sector or in collaboration with the public sector, where it's actually dual research. The other is in actually lessening the burden on the public sector. So, for instance, through AFA, Aid for AIDS, that's been providing HIV programs for medical scheme members and employer groups since 1998. It means that population, currently we're talking about 300,000 lives. That population is suddenly not having to be funded by the public sector. So now it's easing the financial burden for the public sector, but also changing delivery model, because you can, access care slightly differently, but it eases that burden for the public sector. So that's a collaboration. We also have a collaboration, for instance, where we're delivering medication for public sector private patients through private sector channels, and that's something AfroCentric does, for instance, for a whole host of chronic medication. Lots of those kind of examples where partnerships and start to become important.
Dr. Nkateko Msimeki, I really appreciate your time and sharing with us those teachings about the circumstances around funding and the HIV/AIDS program here in South Africa, and also just speaking about what this new partnership with global funding will mean for middle to low-income countries in general. Dr. Msimeki is a medical advisor for Aid for AIDS and general manager for health policy at the AfroCentric Group. Brings the time to 28 minutes past 9.